Uh, Good afternoon. I welcome you all to this sixth Dr. O.P. Ghai Memorial Oration organized by Department of Pediatrics at AIIMS, New Delhi. This is again one of the prestigious oration of AIIMS, and we have none other than our own Professor Ashok Deorari, who is the orator of the day. So may I request our Honorable Dean to please felicitate him before we start the proceeding. To take the proceedings further, I request Head of the Department of Pediatrics, Professor Bagga, to introduce the oration and the orator of the day, please.
Thank you, Dr. Lalwani. It's my prep. So welcome all of you to this oration, which is the sixth O.P. Ghai oration. It began in 2015-2016. I'll just talk very briefly about the oration. And this is in honor of Professor O.P. Ghai, who was our head of the Department of Pediatrics for almost 27 years. Dr. Ghai began his career as a medical student around the time of partition. And he did his MBBS from Government Medical College, Amritsar, following which he did a DCH from Mumbai and a MD from Indore under Dr. Pohovala, who was one of, again, a legendary pediatrician around that time. Subsequently, he came to Delhi, where he began as a registrar at the Irvine Hospital, and then joined the Department of Pediatrics, where he began the Department of Pediatrics in 1959 with 6 beds. And over the next 27 years, he was the chief of pediatrics till the time he superannuated in 1989. During this period, he had multiple accomplishments. He was editor-in-chief of Indian Pediatrics for almost 3 years. He was the president of the International College of Pediatrics. He organized the first meeting of the International College of Pediatrics in Delhi in 1977. And subsequently, he became president of the Indian Academy of Pediatrics. And finally, just prior to superannuation, he was a dean academic of the All India Institute of Medical Sciences. He did get a number of fellowships and awards. I'm not going to go into details on that. But his core areas of interest were, diarrheal diseases, Indian childhood cirrhosis, and so on. Just a few words about him as a persona, And I was a junior resident when I joined the department, and even as an undergraduate, he had taught us. I think the single most important thing that stands out his contribution to pediatrics in the institute and the country is the vision in developing specialties across the institute. When we were, studying here, we already had specialties that were flourishing here, And I think clearly that was something that he really gave to the institute and to the country. The rest of the country took it over the next 10 years, 15 years, but that was one major thing. He was really an inspiring leader, and long clinical rounds. I do remember still, rounds in Unit 1 with Professor Ghai, Dr. Kalra, and Dr. M.K. Bhan, the rounds going on for 2 hours on a single patient. Imagine the plight of the junior residents who were standing there, but they were long rounds, and inspiring rounds. He believed that physicians should have enough laboratory skills. And he used to be so happy, if one would show him a urine exam that showed something different, or the hair of a Menke-Kinke disease, Madhulika is here and others are also here, or at times even a positive aldehyde test in a Kala Azar. So those things, he would feel that pediatricians and physicians should be aware about basic lab skills. This is a legacy that the department has tried to carry on. At times we've been successful, at times we have not been that successful. But that's another, I would remember one facet of him. So over the next 3 decades when he was the chief, he did inspire not only one generation, but multiple generations. He was an excellent writer. He was able to write very, very clearly. He happened to be my co-guide for my thesis, with Dr. Kalra being the chief guide. And he used to always complain that I write 2 long sentences. कि तुम बहुत लंबे सेंटेंस लिखते हो, छोटे सिंपल बनाया करो. And I think I owe a lot to him, from what I learned working with him, that these skills. His contribution to pediatrics on the long term was Essential Pediatrics. And we do know that the book, which was first published in 1982, is now 40 years old. It's come to the 10th edition, and it's the privilege of the department as such, of the entire department, that we've been able to carry this legacy forward. So this book is really the background or the basic book for undergraduates across the country, and not only in the country, but even in South Asia. So clearly, his contributions have been major, and it was a fortunate thing, that many of us were able to were taught by him, worked under him, and this oration is chiefly in his honor. The previous six, so this is the sixth oration. The previous six orators have been Professor Meherban Singh, Professor I.C. Verma, Dr. R.N. Srivastava, Professor Veena Kalrao, and last but not the least, Professor Vinod Paul, who took the oration last year. Professor Deorari has now been selected to take this oration, to deliver the oration this year, and I'll request Ramesh to say a few words about the orator.
I think Professor Deorari does not need any introduction to this audience. I would say that not even to a pediatrician, neonatologist, or anyone engaged in newborn care in this country, Southeast Asia, East Asia, Middle East, even beyond. He is iconic and known by everyone. He spent half a century in this institute, wearing many hats as student, as resident, senior resident, faculty, and head. And in last couple of years, he provided exemplary leadership to the department and to the country, I would say, during the difficult COVID times. We had this sit facility which has just come up, and under his exemplary leadership, he was able to put up a team that is doing such a great work. His research contributions, 250 odd papers, have been cited extensively and led to policy formulation not only in India but globally. He served on many important committees, including President National Neonatology Forum of India in 2020, and currently he serves as a Principal and Dean, Himalayan Institute of Medical Sciences, Dehradun, and the Chairman of Selection Committee and the member of the Institute body of AIIMS Kalyani. So these are some of his outstanding contributions. However, I would say that there are some things about him that makes him dear to everyone, whether that's a 17-year-old young student in the institute or an 80-year-old senior professor. And these are, his passion and exemplary contribution to the education. Number two, his authenticity. And number three, his childlike passion and enthusiasm. I cannot go in details of each and everything, but I would really like to make two of his outstanding contributions in education. And, he developed a system of education of a unique kind. And my favorite was the neonatal ventilation workshops. And this was invented by him some 30 years ago. And these were, to me, benchmark of academic teaching. These were high-class teachings, no frills, no inauguration, no closing, no sponsor, no advertisements. Pay and learn, and very, very high-quality teaching. The student and teachers stayed for all 4 days together, interacted personally, and the quality was such that it became sort of a much sought after event. Initially started with bunch of overseas faculty, but later he created a karma of almost 100 odd homegrown faculty that went to each nook and corner of the country and trained every pediatrician and neonatologist. and then it went beyond the confines of the country. And he trained pediatricians and neonatologists in many countries, including Sri Lanka, Bangladesh, Nepal, Bhutan, Myanmar, Indonesia, and Iran. And it still continues with the same quality, purpose, ideology, and enthusiasm. To me, that's one of his greatest contribution, and that model of teaching that was not only for neonatal ventilation, but done for the kangaroo mother care, newborn nursing, and quality of care. My second point was the quality of care, but since he would be talking about it, so I would not go in detail. But the second thing that I would like to highlight is the development of wide-ranging learning resource materials. And he has always been a very well-grounded person, and he would begin very small and then build upon that. And some 30 years ago, he developed a set of PowerPoint presentation, 12 of them, known as Teaching Aid, published by National Neonatology Forum. And that actually, for people like lazy people like me, that provided, and I did not have to make any PowerPoint if I were to take a class for an undergraduate student. But I think those 12 PowerPoint presentation was used for 15 to 20 years by everyone, practically everyone, for teaching undergraduate students, for teaching nursing students. And it streamlined at that time the education of newborn, the pre-service and in-service education of in newborn health. And later, then he built upon that, and he developed in next 20 years of time everything, and you name it. That includes self-learning resource materials, videos, manuals, books, apps, CDs. He started, he developed 4 websites, and all of them are running, visited by lakhs of people, have been visited by lakhs of people. Online courses, distance learning, you name it. And these resources have been used by lakhs of people across the world and contributed immensely for the education of the health providers. And to the best of my knowledge, no one has ever been able to produce so much word over. And we respect him a lot for all of that. I cannot go over everything, but lastly, I would say that despite being mature, prudent, and insightful in his decision making, from within he remains a 4-year-old child. Sir, this time I am saying the first sentence also, otherwise you'll get angry with me. And someone who is really all the time full of energy, young, smart, and handsome. Someone fond of his phones and watches, good dresses and Hilsa fish. And of course, he enjoys the company of his friends and followers who are always with him. No wonders. He is considered as the Amitabh Bachchan of the fraternity. Thank you very much.
May I request Professor Paul to please come forward? So now I have the honor to invite Professor Ashok Deorari to deliver the oration.
Dean Academic Dr. Minu Bajpai, Professor Vinod Paul, Member Niti Aayog, my senior faculty colleagues, Professor R.N. Shrivastava, Dr. Veena Kalra, who are in the room, faculty colleagues from Department of Pediatrics and from AIIMS family, dear staff nurses, students, this is my honor to deliver this prestigious oration on the name of my teacher and guru. I pay my tribute to great soul. Sir, with your blessings, I stand here. After my MD in pediatrics, I had no job in my hand. I was very scared to enter the room of head of the department at that time. With great courage, I peeped in. Sir looked at me and promptly said, Ashok, no jobs of SR, go and join as a research officer in Department of Division of Genetics. I joined that. Those days, Department of Pediatrics used to have only 4 senior residents. And the senior resident who was senior to me in MD, Anil Gupta, got the job, and I was kept on waiting list for next 6 months. It was 30th of December 1983 that one of the senior resident after 2 years, Dr. R.K. Menon, left for Libya, and I was offered the job the last day because it was not sure in January I'll get the post of the SR of pediatrics. And that is how I started my journey here at All India Institute of Medical Sciences. And I learned a lot of clinical pediatrics while taking rounds. And at that point of time, many times as a SR, you were considered just like a faculty member of the department. You used to manage, along with the junior residents, the entire unit, but always keep informed your senior consultants and professors who were in charge of the unit. I was so lucky that Vinod will remember that incidents that in 1986, while we were senior resident, Vinod also was there as faculty member. We got in touch with Dharampuri Vidyasagar, professor from University of Illinois, Chicago, who used to stay at the residence of Dr. Ghai. And we were just inspired at that point of time that we need to do a lot for improving newborn care in this country by Professor Dharampuri Vidyasagar. And it was Dr. Ghai who made that connection for us. And I still remember going with Dr. Vidyasagar, sonicating surfactant at 3:30 in the night in one of the side labs, and then we gave it to a premature baby to show that hyaline membrane disease can be cured by giving surfactant to the baby at that point of time. This is 1986 I am talking. Now I move to another institution, and I bring greetings to all of you from Swami Rama Himalayan University. It is founded by the great yogi, His Holiness Swami Rama. He preached love, serve and remember. And there is a meaning about all these words. Love is treat your patient with compassion, empathy, be sensitive while you want to treat them. Serve means treat them skillfully. He used to say, even selflessly. So treat your patient and do manav seva and remember, we have to treat rich or poor same way by providing high quality of care which has to be given to the patient. Those of you who have read his bestseller, The Learnings from Himalayan Masters, will go through and read all these things and how experiential learning has to be learned from the knowledge and the skills which are applied for patient care while you are managing your patient. So for me, while I was looking for topic of oration, I thought there can be no other good topic but a topic which can be dedicated for Professor O.P. Ghai, which is on quality improvement, a tool to achieve excellence in healthcare. I disclose that this work, which I am going to share in 4 main headings, is a work not of my work, but is a work of our team of nurses and doctors, resident doctors here at AIIMS and outside AIIMS who have taken this forward. So I am going to allude to 4 areas in short presentation. The first one is going to be talking on quality healthcare, quality improvement, and quality assurance. The second is going to be what is the journey of quality improvement which we have taken from AIIMS to the nation and beyond nation to many of the other countries. And the third is to share briefly the success stories which have been achieved and to motivate younger people that quality improvement can be a work which they can do as they do their dissertation and thesis work. And the fourth one is how we can embrace quality improvement in the education for next generation of student, because times are changing. So these are going to be my 4 areas on which I am going to base my oration. We all know, while we are talking of quality healthcare, it has to be patient-centric. It means putting patients at the center of healthcare. It has to be a care which has to be effective care. Effective means it has to be a evidence-based best practices which have to be given to our patients. It has to be a care which has to be efficient care. Efficiency in care, healthcare, is that we have to avoid waste of resources, money, and time while we want to deliver healthcare. It has to be a care which has to be a timeliness care. A patient who is sick, reporting to ER, must be given treatment right on time. A patient in shock must get the first bolus within first few minutes. Otherwise, the patient is going to have organ damage. Antibiotics to be given for a septic patient right on time. So timeliness of care is very, very crucial, and it has to be provided by skilled and knowledgeable individual. And it has to be a safe care. Safe in terms of avoiding medication error. Safe in terms of following SOPs, protocol, checklists for the patient. Because you have to imagine at one day, it can be you or your relative who is going to get that treatment. So it has to be a safe care to our patients which have to be provided. And the last one is equity of care. Equity is what I said. It has to be a care for rich and poor, irrespective of gender, irrespective of religion. The same high quality of care has to be provided. This is the definition of quality healthcare which was given by Institute of Medicine way back in 2001. In 2014, World Health Organization came with the framework that the healthcare has to be provided by skilled individuals, and the healthcare facility also should be in readiness. It should have manpower and skilled individuals and supply chain for providing quality healthcare. So there is a framework of World Health Organization which is given in 2014. It alludes to providing better experience of care. Again, compassionate care which has to be provided to each and every patient. And this is what is the vision of our government also while they are talking of universal health care to the poorest of poor in the villages. The changing paradigm of healthcare at this point is there are two things which we need to remember. One is quality assurance and the second is quality improvement. They directly apply to each and every hospital. Once we are talking of quality assurance, we are talking of the structure, the SOPs and the protocols which have to be in place. We all know about the national accreditation quality standards which the government of India has laid for public health facilities and health facilities. And I am so happy that Director Sir and his leadership also wants in this institution NABH accreditation, National Accreditation Board of Hospital, to be applied at All India Institute of Medical Sciences. A great step. But remember, NABH is top-down approach. They gave you the compliance of the standards according to NABH which are being followed in the hospital. And then non-compliance has to be filled by the hospital. But what we are talking today is quality improvement. Quality improvement is done by the frontline people, the doctors and nurses who are providing healthcare bedside. They know the problems which are there. They know the solutions which can be a solution in their context which can be applied and it can lead to improvement. And this process is called as quality improvement. It is driven by frontline people as a team. It is a change in their attitude and behavior which has to happen. So for doing this, you need people who have heart for improving care and who understand what is quality health care which has to be delivered. Knowledge in itself by a research scholar has no meaning unless we are able to apply that skillfully. And then if we are applying that skillfully, it has to be safe care. If there are any gaps in there, those gaps have to be filled. And these gaps are going to be addressed only by the team of doctor and nurses, or even the help attendant who is there, who has to make sure that is getting provided there. For doing quality improvement, you use a approach which is called as the PDSA approach, plan, do, study, act, cycle. By this, you test some changes which you want to make, measure it, and then see whether it is working or not. So you learn while you are applying that knowledge and skill at the bedside, and if it is not is leading to improvement, you either abandon it or you adapt it and retest it on small number of patients and then move forward. So this is approach which is called as the quality improvement approach, which is for process improvement. At this point, I would like to share with you that there are 6-7 models of quality improvement which exist globally. It may be a model which Institute of Health Improvement, Cambridge, propagates. It may be a model of NHS UK or a Australian model, or Japanese model which may be a Six Sigma model for improving quality improvement, or a Kaizen method for doing continuous quality improvement. Goal of these, each one is same. It leads to implementation of best practices. It identifies what are the gaps in the processes which are there and how these can be filled on a continuous basis for our patients. It focuses on, as I said, on the frontline people, which are the doctors and nurses who are directly involved in the care of the patient in that particular place. And then this is a change of behavior and attitude, and then making a cultural change in that particular unit or in that particular hospital where you have a structure which is already in place, which is according to NABH or any quality assurance standards. So in India, this is way back 2015, we started thinking about how this approach can be applied in our context in this country. And we started thinking of making a model which will be an India model for Indian context. And we started working on that. It was a team of dedicated champions who joined in that journey and came out with a model which is called as the point of care quality improvement model, which is called as a POCQI model, POCQI model, because initially while we made this model, it was for mother and newborn babies who are getting born in the labor and delivery room and getting care in the postnatal ward. And for that, we had a learner guide and a coaching guide and a facilitator guide how to get this done by learning small examples and then a teaching learning method, which was adult learning basis principles, and then making sure that whatever people learn, they get back to their unit and start practicing and start finding out the problem and try to improve. And the best part was, we try to simplify it so simple that any staff nurse or any resident doctor who has little bit soft heart which is for improving patient care, he or she will immediately grasp this method of improvement. And it was a 4-step approach. Just like PDSA cycle, it was 4-step. The first step and second step and third step, everything has 4 things. First step was problem finding. First, we have to accept we have a problem at a place where we are working. Then what you do is, you say you will make a team. Third is, you write an AIIMS statement. AIIMS statement, and then, yes? So you write an AIIMS statement, SMART AIM, and then you move to step 2, and then you use some tools to analyze that problem. For using that, we used to teach only 4 tools. The tools used to be 5 whys, flow Pareto chart, or a root cause analysis using a fishbone analysis, or a flow chart, especially for patients who are coming to the outpatient or to the OT. You want to improve that flow of the patient, you use that flow chart for finding out and tracing out what the problem is. And then we used to teach that there has to be a numerator, because measurement is a part and parcel of QI. That unless you measure what you are doing and how you are improving, you can't say you are making an improvement. So for that, we used to have a numerator and a denominator and a XY chart, which is a run chart on which it used to be depicted, and then using statistical method of making an analysis of that, whether improvement is occurring or not. And the fourth one is with a control chart. So run chart, control chart, numerator, denominator, again 4 things in step 2. And the step 3 used to be testing that change. Change ideas used to come from the team, and they were tested on small number of patients. And then whatever used to work used to be either adopted, adapted, or abandoned. And then you used to sustain that change. And then with the help of your run chart, you are able to see whether you are making improvement. Quality improvement is a process which is a continuous process. You improve one thing. What happens is you get interested in improving more patient care. It may be a simple thing which you want to improve, but you will get interested once you learn the tool that more and more improvement can be done on continuous basis. I am showing you few areas which are listed here, which can be easily improved using a quality improvement methodology. NABH people will tell you about the compliance of these or not. But if you have to improve these, you need quality teams and a champion, and then a process by which you can measure that you are making improvement. Reducing waiting time in the outpatient, improving patient experience with OPD consultation. Patients may be unhappy, but how do you improve it? How do you change it? That is by finding out the problem and getting to the root cause and addressing it. Reducing transfer time of an ER patient who is sick from the ER to the wards. Discharge a patient from the hospital. This is a chronic problem. The resident doctors don't make the discharge slip before 12 o'clock. The family is waiting. They want to go home. They have made all the arrangement, but the discharge slip is not signed. Or maybe the finances are not cleared for the hospital bill. So discharge of patient can be improved if you follow a quality improvement. Use of surgical checklist. Implementation operation theater. You talk to anesthetists, surgeons, everyone will say, yes, we are applying it. But if you ask them, are there some gaps which are still occurring? Because if you don't look for the gaps, you will say everything is fine with me. There is no problem in my unit. There is no problem in my operation theater. Everything is fine. Unless there is some near miss or something wrong happens, then people start jumping and start doing the root cause analysis. So I am very sure most of you have read the book by Atul Gawande, Complications. What he writes is, if you ask doctors and nurses, would you like checklists to be implemented in your place? Most of them will say it will increase the work. Not really interested that we should apply checklist. You put another question to them. Would you like checklists should be used while you are getting operated or your sister is getting operated? Yes, yes, for sure. For them, the checklist should be there by the anesthetist, by the surgeon, or anyone, staff nurse who is there in the OT. Why? Why that distinction? Why not to each and every patient who gets care in the hospital? So improvement audits for near miss, people do it by root cause analysis. Tracking key performance indicators, especially urinary tract infection following catheterization in prostate enlargement or in urology department. You will like your patient to be admitted in that unit where UTI rates are less. So this is one of the key performance indicators which tell you which unit is doing good or bad. A patient who is after surgery having post-operative complication, surgical wound infection, it is not better to go there. It is better to go to a place where surgical wound infections are less and less. So I am very sure in times to come, all these things are going to be on public domain. And that is what is needed in majority of the hospitals in the country at this point of time. Now, a lot of people will ask, why should I do QI, Dr. Deorari? I am a clinician. I am a clinician. How does this help me? I tell you, it really helps you. You will find your patients are happy. You will have immense joy and satisfaction. Your patients will go home early. You will find that it adds value. You save money also if you start doing quality. The best part is for younger people, they learn how to collate data, how to put the data into use, how to make chart and look at how the improvement is occurring. So it saves money, gives joy and satisfaction. So I would say part and parcel. Like a thesis or a publication in journal, it will give you opportunity for making presentation in conferences, national, international. It counts for professional growth in Western country, but not in India, because we have not given so much importance to quality improvement at this point of time. But I am very sure under the leadership of our director, sir, it is going to be part and parcel of the appraisal process. Now this slide I would spend a little bit more time because it is meant for the younger generation. Younger generation. For younger generation, publications are driver for professional growth. They look for only publications, publications, publications. So I am giving you option here. You can get publications by doing quality improvement work. There are more than 30 international journals at this point of time which publish quality improvement studies. I did a PubMed search for you. Just putting few keywords, I found more than 12,000 publications in PubMed in last 5 years. And while I look in India, out of these, nearly 600 are from India. 600. And many of them has used the Indian model, which is a POCI model of quality improvement. And the best part is, at this point of time, there is a way by which you have to write your quality improvement project. Just like you do randomized control trial and you have consort guidelines, you have Square guidelines, Square guideline 2.0, which are standards for quality improvement reporting excellence. They are published, how a QI article has to be written, how a thesis has to be written for that. So you get the opportunity of doing the same type of work. And to me, while I look at nationally, Vinod is sitting here, Vinod was there earlier in the BOG. Talking about nation, I would say hardly any of the dissertation or thesis which are done in majority of the medical colleges. And Vinod, we have 70,000 dissertation and thesis coming out. And I would say small sample sizes, poor research questions, majority are descriptive study. They are not aligned to what patient needs at this point of time. And we are unsure about the quality of data. That is the reason they don't get published. And I notice even in centers of excellence, we know this is happening now. Not all dissertation and thesis are resulting in publications, though we want each and every MD student or DM student should publish it. But it does not happen because I have seen that while I interview people for faculty positions. So at least do something. Do a work which will be directly benefiting patient care. Do it skillfully. Measure it, just like you do measurement for your thesis or dissertation work. Do it. And in 2018, we came out with entire issue of Indian Pediatrics, which has 20 stories on quality improvement. So quality improvement is just like research. Research, it gives you dividend like research. Research is, it needs money, more time. Your protocol is fixed. In quality improvement, your protocol can keep on changing as you keep on testing with your PDSA cycle. But it has to be done in the local context. And many times, it doesn't need even the IRB approval for doing a quality improvement work. Now, at this point, I would get to journey so far quickly to share how we moved from AIIMS team in India to CRO region in Africa. And here is how it started. This started in 2015, on 15th of August. Dr. MC Mishra, then the director, made an announcement suddenly on 15th of August that Dr. Deorari will lead a quality improvement initiative. I had no idea what he is asking me to do. And then we moved. And then in September, we made a presentation in front of our health minister, Nadda ji sir. He visited, and we shared 6 success stories on poster during Institute Day. This was in 2015. And following that, with Dr. Mishra's support, we started spreading among the nursing colleagues and the resident doctors and even the faculty members, multiple quality improvement workshops we did, 2015-16. And at that point of time, I think it would have not been without the support of US Aid Assist and Nigel Levensley, who really had total heart into doing quality improvement. And then we moved. We moved and did 2 grand rounds in which our previous directors also visited and listened to what the AIIMS doctors are doing on quality improvement, all the stories. And we were lucky that we were supported by US Aid for doing 3-month capacity building workshop, which was blended type here in this very boardroom, in which we called all the AIIMS and the Centers of Excellence faculty here in this very boardroom, which was all paid by US Aid. And then we moved to Bhutan, Nepal, and the other countries for doing quality improvement. So the quality improvement network in last 7 years with the new AIIMS, medical colleges, state government, DMEs, medical education, and NHM, we spread all across. Many workshops we did across the country. And then we realized that the change agents are going to be only the next generation. Only senior people need to support them, and the next generation will make that quality gets embeds in the system. Then Dr. Guleria came. Dr. Guleria was also on board. And then I think it was a Shimla visit, Vinod, before you joined Niti Aayog, I still remember. Dr. Bhan was there. We were in Himachal, your own state, with the state government and DME. And my teacher, Dr. Bhan, blessed me at that point of time and motivated me. In front of you, you were there on the dais. Ashok, continue this, don't leave it. Your passion is in QI. I said, I'll do it, sir, for a few years and leave it to the others to take. He said, do it. And this was in 2017. It was in Dharamshala, Vinod, if I remember. And here you see Manoj Jalani, who was the additional secretary NHM. He was very instrumental in getting QI into the Lakshya program, which is labor delivery room and operation theaters for mother and newborn care. And then we created a website with an app on mobile phone in which within 4 hours people can learn and generate a certificate of quality improvement. It is still there and a lot of resident doctors take it. So we started with POCI 1, we came with POCI 2 and then made a district model, and I'm so happy at this point of time, even the education cell of the Indian Academy of Pediatrics want to take quality improvement in education. The success stories, very briefly I will share with you, are done by Department of Obstetrics and Gynecology, Emergency Department, Ophthalmology, Surgery, Nursing and Pediatrics at AIIMS, New Delhi, and many more whom I may be missing. And here are the champions of those. Champions of improvement at AIIMS. And a single person who has been catalyst is shown on the right side, Deepak Chavla from GMCH, Chandigarh. He was the person who kept the fire alive in me by, he's my student, just telling and asking me, sir, this is new which has come, this is new, sir, kindly get this done, get this done. So he was the catalyst for doing it. And then we have champions who are sitting, many of them are sitting in this room. Aparna Sharma from Obstetrics and Gynecology. She made a network of medical college, obstetrics department for educating quality improvement. She took to her professional society also. And then she did publications on quality improvement. And if I am correct, I read Aparna's publication on birth companion during COVID, a quality improvement study which is published, Aparna, and how respectful maternity improved from 0% to 90% in your labor room during the COVID time. Use of investigation checklist for admitted antenatal care mothers as a quality improvement study, how it improved the care of the mother. You have many more publications which are there in literature. Second name which comes to me is Akshay Kumar in casualty. Real gem of a person whose heart is there in QI. He published a lot of articles in high impact journal of the QI work which he has done for improvement of patient care in the ER. And the one work which I would like to share with you is that reducing time to perfusion time for STEMI MI patients reporting to ER, which was 22% used to be done within 90 minutes. He made sure it is done in more than 70% of the patients. It's published in BMJ Safety and Quality. Akshay from. Then we had nursing leaders. Leaders like Meena Joshi, she's sitting here, nurse in charge in the NICU, and her job was to make sure all the nurses are on job. Resident doctors also are part of the QI team. Small things, and she would make sure that each week the quality indicators of the NICU are put on the wall in the form of, so that anyone who is going in, he knows what is the compliance of hand washing. How many mothers are doing kangaroo mother care eligible mothers? How many babies are getting exclusive breastfeeding in the NICU, like 100% is EB. And then she will put that every week and keep the team motivated. So great Meena Joshi. And then we had Dolma. Dolma is in charge of nursing education at RP Center. Wonderful work. She not only did in RP Center, but spread to CN Center, ER, Trauma Center, and even moved to your own professional organization for taking it forward. And then Parijat Chandra. Parijat Chandra was the first one who published 2 articles on quality improvement with his young doctors, how to reduce OPD time and operation theater reporting time for patients for eye surgery for children. And the best part was Parijat took the lead for maintaining our website. That was one. Second is running the IHI chapter, which was for free, in which a lot of people can have access to the teaching learning resource material. I forgot Annu. Annu also was part of the team. And here are 2-3 good publications in which I was small part. It is done by our team altogether. It was improving the quality of healthcare in special newborn care units before and after intervention study. using a QI approach and teaching learning methodology, which used a premature baby package. And while we started this in 2018 in the SNCUs, we noticed the antibiotic overuse which was there. It reduced over a period of 6 to 8 weeks by nearly 50%. Oxygen use, which was rampant, also reduced significantly. And the units were able to save each year nearly 75,000 rupees for saving oxygen cylinder, which was getting overused in the unit. So it was, and then babies were kept in NPO. So they started getting oral mother's milk in that particular. So this is all published work. And then we did remote mentoring of a facility from here as a part of DM dissertation at Shimoga Medical College. And you can see all the indicators which were there. They either improved while it was done hand-holding. And the resident doctor who did his DM, he's back to that particular hospital, and he is able to sustain that for a period of nearly 18 months, which is going to be published in the latest issue of IJP at this point of time. And the last part is QI in medical education. Quality improvement can be embedded just like we are doing quality improvement, because it is an approach of making improvement. Our teaching learning method have to improve. Our assessment method have to improve. So unless we accept that we need to make an improvement in how we deliver contents to the student, whether the students are able to get it or not, how we can improve our assessment methods of the student, unless we spend our energy and time and making a framework and making an improvement and show by measuring that improvement is going to be a part and parcel, we will not make a dent. Times are changing. AIIMS can't stay away from how the world is changing or how the nation is going to change. On the other hand, AIIMS has to be a leader. You have to show the light to all others. So we must try to get QI curriculum in medical training for both nurses and doctors for UG and PG education. QI is a management principle. They have to be taught. And the process of education using adult learning principle is part and parcel of CBME education of NMC. So skill and simulation also has to become a part and parcel while you want to educate your next generation. This cannot happen unless we educate our faculty what the quality improvement methodology is, because this is a management approach. It is not taught to you in the MBBS, UG curriculum or a PG curriculum. It has to be taught and learned by practicing. Knowledge is not enough. Skill is also not enough unless you apply that knowledge and skill and learn from your experiences what works well, what is not working. That experiential learning has to happen. So we have to have didactic teaching. We have to teach the skill and tools, but experiential learning, that means small projects have to be given to UG students and PG students on quality improvement. And then faculty need to be, this has to be part and parcel of. And how do you measure the outcomes in education? Education research is difficult to be done. This is how you can measure it. Either you can measure the satisfaction or the learning or the impact or results or returns on investment. If you are looking at satisfaction, only is Likert scale. If you are looking at learning, you can have pre and post MCQ and OSCE. You can have focus group discussion or a mixed method approach. If you are measuring of impact of teaching learning, then what you need to measure something else. If you are teaching people knowledge, skill of intubation, you need to see how many times, how much time the student is taking for doing intubation, how many times it is a failed intubation. If you are teaching hand hygiene, how much is the compliance of hand hygiene which is happening to the people. It is not only knowledge and a skill, but it has to be in practice. And that practice also has to become a habit. Habit is only in one individual, but you have to make that as a culture. Culture is that each and every individual who is not sensitized also will start following that. We need a cultural change in our health system if we have to follow and make quality improvement. And then results and return on investment is in terms of how many scholars we are producing, how many awards AIIMS graduates are getting, what is the portfolio, what is the 360-degree feedback of the graduate student based on what the students are saying or what faculty. So if you are doing educational research, This is the way you have to do it. You have to have your outcome, which has to be very clear, and you have to measure that outcome. And then your imagination. It can be a Nobel laureate, whether it's coming from university. So these are your imagination, which is on value, how much you are putting your money for doing that education, and what your students are giving back to the society. So that is how you measure. And the last but one slide is, at this point of time, simulation is combined with quality improvement. Here is one study which is published from Norway, reducing the door to needle time in stroke thrombolysis patient in the ER. It is published, and it shows that the median time reduced from 27 minutes to 13 minutes, nearly half. While they did the QI simulation exercises in batches, and it was a randomized study which was done before, and then also looked at what the outcome was at 90 days of age. The mortality and disability decreased by 1/3 while you use QI and simulation for educating your team, which was there in the ER. Last slide is on experiential learning model in healthcare. And I think this comes from the teaching of Swamiji and Guruji also. I say, number one, that first of all, our 3 H's have to be aligned. 3 H's is, first is, H is head, your mind. The mind has to be focused, mindfulness and commitment while you are engaged in patient care. Second is heart. You should be compassionate. There should be a desire to learn from the mistakes and experiences. And I tell you, this will build your intuitive power and make you a real good clinician. And the third H is your hands. Your hands will perform if your mind and heart, they are in sync with each other. Knowledge is in abundance. Google Baba. Everything is there. Skills also people can learn. But unless you practice those skills and learn from the mistakes and the good thing which you do, you will not make a good experienced physician. And that is your inner conscience, soul. We should be ready. That it should be ready to learn from the mistakes and the good which you do for the patient. And then it moves in that cycle. Okay, so this 3H model is what drives quality improvement. So our team's learning has been over the years that quality improvement is a common sense approach which can be easily done. But what you need is good heart, good soul, mind focused with a commitment. You want to improve the patient care. You want to provide safe care. You don't want to create medication error. It can be done within existing resources. People keep on asking, give me more money, give me more thing. It is whatever you know, whatever skills, knowledge you have, learn from the practice, whether you are able to apply or find out the contextual solutions which are there. Teamwork is the key. You can't do alone. It is a team which is responsible. Measurement has to be part and parcel. You must collect data to show whether you are making an improvement or not. It results in implementation of best practices. It fills no to-do gap. For this, leadership support is required and a local champion. So at the end, my request to Director Sir is not there, but Dean Academics is here, is that we should add quality and innovation as 4th and 5th pillar to AIIMS Trinity of Mission, which already we are doing, but we should come forefront and say it very, very loud, that AIIMS has 4th and 5th pillars also. One is quality and innovation in the mission statement. And we must sensitize our next generation to value of quality in healthcare by introducing this in pre-service education for nurses, for doctors, and it should also be Rajiv Sir, who is our Associate Dean, should be a part and parcel, just like we are doing for skill and simulation lab, for the annual appraisal process of the faculty members and the nursing colleagues for better patient care, in addition to doing education, research, and best clinical care at All India Institute of Medical Sciences. Thank you so much for your time listening to me, and I dedicate all this to my guru, Professor O.P. Ghai.
Thank you, Professor Deorari. Before we hand over the memento to you, it is a mesmerizing day. Let me tell you, I am a pediatric surgeon. I have grown here for the last almost 40 years, rubbing shoulders with who's who of. Today, under this roof, we have a galaxy of pediatricians, starting from Professor Srivastav here. 2 days back, Dr. I.C. Verma was here. Professor Kalra is here. We have Professor Paul, and the next generation of torchbearers, Dr. Bagga, Dr. Pankaj Hari, and so on. So we have grown together. We have seen those corridors. I would just briefly mention about Professor Ghai, and just as Dr. Bagga mentioned, he was a tall figure. He was a visionary, but he was as humble. I'll narrate you one incident. I couldn't hold on to that. Third floor of the pediatric was our pediatric surgery and pediatric medicine OPDs. We used to walk down. If you have to go to the ward, we have to go down the corridor on the third floor and then take 2 stairs up. In between, there is a shutter door. Periodically, directors came out with some memoranda that any faculty has to carry his identity card. होता है फिर हो जाता है फिर बीच में. That on those days that circular was there. The any faculty who has to walk down the corridors has to carry a. There was a new guard. I was coming back from the OPD towards the ward side. Dr. Ghai was ahead of me with 4 or 5 people with him. The guard was new. He stopped him. I'm talking about 80s. A senior guy like him was stopped. People around him were fuming. You don't know who is he? And this gentleman said, stop them. He said, ये अपना फर्ज अदा कर रहा है. I was behind him. I heard it. Those were the times when the heads of the departments and professors were pompous. अंग्रेजों के समय की बात थी. उसके बाद का पीरियड था. I mean, professor is walking down the corridor. 2-4 लोग तो ऐसे ही बेहोश हो जाने चाहिए. Kind of. But look at it. I was worrying at that time. It was very impactful on my mind. Dr. Bagga alluded to his nature of insisting that every clinician should be able to do bedside test. We talked today about point of care test. He was of that time. Those were the point of care tests of those times. And I think he was very particular about it. About Dr. Deorari, as I mentioned, we have grown together. In pediatric surgery, he was in pediatrics. We heard how eloquently he gave his talk with conviction, the kind of passion he has, the clarity with which he spoke. And this has been there with him even when he was a resident. That is the beauty of it. He has maintained it. And he has been there like this forever. His passion is very contagious. He could show an army of people who have been kind of indoctrinated by him. He showed 7 or 8 people, including Anu and others. I can vouch for many, many more, because he has rubbed his passion on us also to a large extent. And therefore now he's in a different sort of world, a little more spiritual, and that was also seen, that you have told us many more things. With these words, thank you very much. We are very grateful to you, all of you, sir, who have come here today, and we can now go in for the next step, please.
Now it is time to felicitate the orator. May I request Honorable Dean, Associate Dean, Professor Paul, Dr. Bagga, Dr. Srivastav, Dr. Veena Kalra, ma'am, please. Last, sir, 2 minutes. So we had an excellent discussion from Dr. Deorari's clear-cut message of quality improvement to achieve excellence in healthcare. And what sir has suggested that we should have quality in our Trinity of Mission. In case you have seen our presentation for last 8 years or so, in Trinity of Mission in between we have 3 important concepts what sir has suggested. It has been there since long, that is quality, innovation and digitization. So all 3 we are working on since long. Another thing which we have heard in last so many years that pediatric department is one of the best department of the institute, and there is no doubt on that. May I request all of you to give a big round of applause to Dr. Deorari for such a passionate talk, and something which has come from his heart, one could see from his presentation. To come to this end of the session, may I request Dr. Rajiv Kumar, Associate Dean, to deliver the vote of thanks, please.
Thank you, Dr. Lalwan. It's customary to do something called a vote of thanks. I was looking up the etymology. When you say vote, I'm assuming people can vote and say, we don't want to thank this guy. So I'm assuming that's why the word vote probably came up. But if I know Dr. Deorari, and I've known him now for 30 odd years, he's been teaching us virtually every single day that we've met him. He would find you no matter where you were and he would teach you. Probably doesn't expect a thanks for teaching because it is something he would probably get up in his sleep and do if somebody gave him the opportunity. Nonetheless, we would like to thank him for a lot more than just this oration. I think that's what's been brought out from what you've heard from him and what you've heard people speak about him. We'd like to thank him for actually the contributions that he's had to building an institution like this. And like Sanjeev actually said, the Department of Pediatrics has had a lot to contribute in terms of building this institution for what it is. There are numerous hospitals, there are numerous medical colleges. We've discussed this many times. What sets us apart from everybody else? Why are we different from everybody else? It's not our buildings, it's not our money, it's not our infrastructure, it's our people. And Dr. Deorari and some of the orators from this department who are sitting in this hall, 4 of them in this hall actually, epitomize what this institute stands for is. And that's what we thank him for, and that's what we thank this department in particular for, among many other departments, and the 4 leaders of this department, and of course the future leaders that Dr. Lalwani of course talked about, for setting up this institution. So thank you, sir. Thank you, Madam, Professor Srivastava, Professor Paul, everybody from this department, Professor Bagga, and of course the whole team from Pediatrics, for making the institution what it is. And thank you for being here to support us in the past now, and I'm sure we'll keep asking you for support in the future. So thank you for that. We also I'd like to take a specific moment to thank the people of the academic section. We don't often name them, but they often work behind the scene. An academic section doesn't mean the 3 of us. We're just the symbols of what is done on the background. It's the people at the back of the sections who work behind the scenes to make things like this work. We take a lot of things for granted, but they work. Telemedicine, they may do a lot of things to make this work, and we don't name them. And finally, of course, the Department of Pediatrics for being here, for being a part of this oration, and of course for doing everything that they do to make this institution great. So thank you, everyone.
So may I request all of you to join us with a cup of tea outside, please.